Hello, my name is Dr. Prashant Deshpande. Welcome to Dr. D's Table Talk. The purpose of this video channel is to provide basic understanding of the common medical conditions and facts based on science. In this video channel, I plan to interview experts in the medical fields and want to cover topics ranging from vaccination to healthy diets and everything else in between. Welcome to another episode of Dr. D's Table Talk. We have with us today Dr. Silvio Marra, who is a ear, nose, throat specialist at Century Ear, Nose, Throat in Overland Park. He has been in ear, nose, throat specialty practice for the last 25 years. He did his undergrad in chemical engineering from Cornell, and he did his medical school at University of Illinois in Chicago. He subsequently did his ear, nose, throat specialist fellowship at Loyola, residency at Loyola, and also rotated through Children's Memorial Hospital, then now Lurie Children's Hospital. Welcome to the program, Dr. Marra, and thank you for your time.
Thank you for having me.
So let's jump in right away into the topic, which is very interesting, which is very important, and we see a lot of pediatric patients with this particular topic. So what are tonsils?
We have, tonsils and adenoids are lymphoid tissue, which are responsible for processing viruses, bacteria, fungi that we're exposed to and developing our immune response to those entities.
Okay. And what is the general progress of these tonsils and adenoids in a child, say from infancy all the way up to adulthood?
It's slightly different for both, and one thing to understand too is that, it's easy to say there's essentially three tonsils that we have.
Okay.
Adenoids, which we call adenoids, understanding that is essentially the tonsils of your nose. There's the tonsils that all of us recognize as our tonsils, of which there's two of them, right and left side. And there's actually a third entity of tonsil called lingual tonsils, which are inside the tongue. And that they may manifest if you've ever heard of the circumstance where someone says that their tonsils grew back.
Right.
The majority of time, our tonsils don't grow back when we remove them. However, a lingual tonsil can actually come to the surface and give the appearance of a new tonsil growing back again.
I see.
As tracks from, younger children, infants, we tend to see more upper respiratory infection affecting the ears and the nose. And as a result, it's our adenoid tissue which responds to that, which tends to grow a little bit larger in those earlier years and then fades back in size as then the tonsils become more prominent, as throat infections become more common, typically around, kindergarten, first grade time. And then, from the concept of adenoids, adenoid tissue actually will eventually involute and go away. By the time someone's a teenager, most of us no longer have our adenoids as any kind of ability to obstruct us or cause any symptoms anymore.
Okay.
Unfortunately, that does not happen with our tonsils. It'd be great if our tonsils disappeared because it would help, the later teenagers, young adults, older adults from having throat difficulties, but our tonsils do not disappear. And in general, at least in my experience, while they may shrink a little bit, assuming we're not getting a significant amount of thorn infections, your teenage size of your tonsils will in general remain the size of your tonsils throughout the remainder of your life.
Do tonsils vary in size? Sometimes we have heard large tonsils, small tonsils. If you could kind of explain to us with some images, because a picture speaks 1,000 words. So we're just wondering, are there different sizes of the tonsils, and how do children present differently when the tonsil is large versus the tonsil is small?
We have a grading scale that's, it's a simple grading scale of 1 through 4 in terms of tonsil size.
Mhm.
1 being, small, insignificant, not creating any size problems, up to a maximum of 4 where the tonsils are significantly enlarged. You'll hear the phrase kissing tonsils, where they're actually touching each other. They may be obstructing what we call our uvula, or a little dangly thing that hangs in the back of our throat. And then you have, the intermediate sizes of 2 and 3, where 2 is, essentially normal size. 3 is enlarged. 4 is excessively enlarged. When you're getting to these 3 or 4 numbers, the size of the tonsils at that point start to create problems for the kids with obstruction, right?
Right.
The number 1 sign of obstruction being snoring.
Okay. Okay. So is it that tonsils cause snoring, or adenoids, or both are capable of causing snoring in a child?
Yeah, I would say both, right? Snoring happens because there's an obstruction at one of 3 levels, or a combination of all of them. Our nose, in which adenoid could play a role in that. Our tonsils, because that's the palate, which includes the uvula and the tonsils, and then the base of our tongue. For children, nose and palate are the primary sources of obstruction. And when I evaluate a child who's coming in because he's snoring or having blockage problems, that typically is disrupting sleep, because that's when it's elevated to the level that, an ear, nose, and throat may be involved. I'm looking in the nose to understand, is the child having obstruction in the front part of their nose, which would be typically from allergy type problems, or are they having problems in the back part of their nose, which would be, their adenoid tissue.
Right, right. So we have commonly heard terms sore throat, tonsillitis, pharyngitis. What do they mean? Are they same? What is the difference between sore throat, tonsillitis, and pharyngitis?
Sore throat is the symptom that, your throat hurts.
Right.
Pharyngitis and tonsillitis are assigning a location to what part of the throat the inflammation is present in and causing the pain.
Sure.
For example, if you no longer have your tonsils, you cannot have a sore throat coming from a tonsillitis. You would be given you would have a pharyngitis. And a corollary, you can still have your tonsils and have a pharyngitis, in that either the back wall of the throat is inflamed, being the source of the pain, or, the tonsils not being infected. When the tonsils themselves are swollen, red, when there's exudates, which are the white spots on the tonsils, that's when that's when you're calling someone a tonsillitis. And in general, pharyngitis is a little bit more of a general anatomic term, meaning that it encompasses your entire throat. Tonsillitis is very specific to only the part of your throat where your tonsils are.
Right. So do all tonsils need to come out? What tonsils do you usually tend to remove, and for what different indications? You always worry about that.
Right. As I always say, in the old days, it used to be that, both wisdom teeth and tonsils, just by the virtue of their existence, they were removed.
Right.
Fortunately, we now understand that, there's immune system function to our tonsils and adenoids. These structures are important, especially in the first 3 years of life. So we don't go remove them indiscriminately anymore. We're looking to understand, the 2 most common reasons why someone has your tonsils and or your adenoids removed are that they're large and they're causing obstructive problems, which are interfering with proper restful sleep of the child, or B, recurring infection.
Right. Sometimes we see in our practice, children and parents complain that their child has open mouth when he or she is sleeping. So what does that indicate to you?
At that point, you want to examine a child like that, because you want to look at the nose to understand, as I explained before, is the front part of their nose obstructed? Because open mouth posture breathing is occurring because the child cannot breathe properly through the nose, right? We're all designed to breathe in through the nose, out through the mouth.
Right.
If there's an obstruction there, someone's mouth will be hanging open. It's not good for dentition. It's usually not good for sleep quality. And we have to understand, if is it the front of the nose that's causing the obstruction, because that will be from allergy issues, which typically is amenable then to allergy treatments.
Right.
If you look in the nose and the front of the nose is not swollen, with sometimes with just visualization, you can see the back part of the adenoid tissue.
Right.
Sometimes we put a camera in the nose to get a visualization of the adenoid tissue. On rare occasions, when they're extremely large, you can actually see adenoid tissue inside the mouth. It's literally hanging down into the person's throat, creating blockage issues.
Right. Obviously, no discussion about tonsillitis or sore throat can be complete without discussing strep throat. So can you tell us what strep throat is? And we have often heard parents and children complaining about getting recurrent strep throats. If you could let us know what strep throat is and how many times a strep throat a child can have before you would consider, as a rule of thumb, to remove tonsils or take other measures. Because we don't want to put these kids on antibiotics all the time. And a corollary to this is that all sore throats need to be treated with antibiotics.
So, this leads into the question when you say, if you're assigning someone, if you're telling a parent your child has tonsillitis, that is implying that there is an infection of the tonsils. As we know, infection can either be viral or it can be bacterial.
Right.
Viral infections, do not need to be treated with antibiotics. You need supportive measures, anti-inflammatories, pyretic to bring fever down. Bacterial infections of the tonsils, of which strep is the number one, bacterial infection that needs to be treated with antibiotic.
Right.
And the reason we say that is that, if you have a viral infection and you understand that, in the office, when the patients come to your office, you can do a rapid strep, which is relatively sensitive to let us know if the person has strep. To some degree, there are visual cues that when we look in someone's throat, it's more readily apparent that there's a strep tonsillitis, right? When you see that there's the red spots around that uvular dangly thing, when the tonsils are red and inflamed, that's highly suspicious that there's a potential for strep throat. We identify that with rapid strep testing. And that requires an antibiotic because, unfortunately, strep is not a nice bacteria. In pre-antibiotic days, people would run into, cardiac issues, kidney issues.
Right.
We don't want somebody having recurring episodes of strep tonsillitis. And, again, because we wanted guidelines in terms of when is enough in terms of infection, the national guidelines that have been developed, and obviously there's nuance to everything, but 6 episodes of strep tonsillitis in a year.
Right.
Because you can always say that, there may be a bad year. And if it's that severe, that should warrant removing someone's tonsils. 4 infections, 2 years in a row, or every year the person's getting, 2 or 3 infections, and it's a relentless, nonstop problem, which interferes with productivity, be able to concentrate, need for antibiotics, which we understand that, we don't want antibiotics if possible.
Right.
They're a necessary entity when somebody has a strep throat.
Yeah.
Now, the reason that you don't necessarily want to have tonsillectomy if you're not meeting these guidelines are, as we mentioned before, there actually is some immune system role to both your tonsils and the adenoids. So we don't want these structures removed if there's not significant issue happening.
Right.
But on the other hand, especially when people start to meet these numbers of infection, I was to make the explanation that the strep has now become intrinsic to the person's own tonsil. That's why removing the tonsils is actually beneficial for reducing the amount of infection, because the person is literally reinfecting themselves from their own tonsils with the strep. Remove the tonsils, it's still possible to actually get strep tonsillitis, strep pharyngitis, because there's no more tonsil, but the likelihood of that is markedly reduced.
Right, right. So sometimes we have heard ear, nose, throat specialists removing tonsils. Sometimes they're only removing adenoids. Sometimes they're removing both. If you could elaborate on what are the different indications for different things, and I sometimes feel just easy to get both those things out and get that over with. Is that a reasonable thought, or what are the different indications for removing tonsils and adenoids versus adenoids only, in your opinion?
Well, when it comes to, if we're starting off with the adenoids, remember, if adenoids are large and they're causing nasal obstruction, attempts to reduce adenoid size, which we normally do with, allergy treatments, with, use of the nasal steroids like a Flonase, if those are unsuccessful and the obstruction problems are leading to one of two issues, most commonly, especially in the younger kids, are going to be recurring ear infections. Our ears drain into the back of the nose where the adenoids are sitting. And recurring ear infections, through two potential mechanisms, are being harmed by our adenoids. One is that they may be large enough so that mechanically they're blocking our ear from draining properly, or two, they're harboring, bad bacteria, which then retrograde their way up into the person's ear, creating ear infections. So we'll remove adenoids alone if somebody's having obstruction problems and their tonsils are not large, but they have inability to breathe through their nose. In treating that, we're not able to allow them to breathe through the nose. We'll also take adenoids out alone if a child is having recurring ear infections after they've already had one set of ear tubes, which is its own discussion. But my normal indication to say, if somebody's getting recurring infections, we've put one set of tubes in their ears, the tubes have come out, the ear infections are occurring again, we're needing to replace them at that second setting because you're hoping not to be there for a third setting of tubes. We remove adenoids at the same time that you take out, that you're inserting the second pair of tubes in a patient's ears.
Right.
When it comes to removing tonsils and adenoids together, remember that tonsil and ear issues are completely separate. Okay. If somebody's having recurring ear infections, it's extremely rare that you need to do anything with their tonsils unless they're also at the same time having like a recurring strep throat issue. Right, right. So in the face of adenoids, because somebody keeps getting ear infections, we don't remove the tonsils unless there's the additional problem that the tonsils are so large they're causing blockage problems. If they're 1+, 2+ size, the tonsils don't need to be removed because their removal is not beneficial to reducing the ear infections. Right. When we remove tonsils and adenoids together, that's typically in two circumstances. They're both large and they're causing obstruction, meaning that the children are not getting proper, adequate sleep. Large tonsils and adenoids can affect our ability to eat. When you're very plugged up in your nose and your throat, you're chewing your food, grinding it down into a slush that you can swallow. And those kids, the parents will be noticing that they're the last one at the table because everybody else while the other kid's going to gulp their food down possibly, and that child just has to be making a solid into a liquid, or I wind up hearing from parents, the kids are somewhat averse to the more solids just because they're actually gagging themselves if they have a larger piece of meat, and they'll just as soon not eat that then. Right. So the other circumstance, so from an obstruction, if they're both large based on open mouth posturing, snoring, these additional signs of some eating trouble, so forth, we remove them together. Recurring strep tonsillitis, typically in kids that are 10 and under, tonsils and adenoids, we remove them simultaneously because the adenoids at that point may also be contributing to some of the strep tonsillitis. Right. But as we discuss that, as we get older, as we start to get into the teenage years, luckily the adenoid goes away. If somebody's having strep throat issues at a little bit older age, after, as they get into their teenage years, it usually turns out that we wind up only having to remove someone's tonsils because their adenoid tissue is essentially disappeared and it's not responsible for the infection anymore at that point, the throat infections.
Yeah. Sometimes we tend to see a 14-year-old walking in with large throat, not able to swallow, hoarse voice, and pus in the tonsils. What do you think about those kind of cases? And
when some, the other thing is that when you start to get the teenagers and older teenagers presenting with a sudden onset of swelling of the tonsils, you see the exudates, you start to think, okay, the most common, in assuming that that person does not have a strep throat, you start to think of, does this child have mono, right? Teenagers can get infectious mononucleosis, which is a Epstein-Barr family virus infection of their tonsils, which usually makes the tonsils get very swollen in a circumstance that they hadn't really been swollen like this before. Usually at the same time, the glands or lymph nodes of the neck will swell up significantly simultaneously, which will alert us to the fact that, hey, there's more to this than just either a simple strep throat or a more benign viral infection because of the severity of the obstruction happens. In those cases, that is the one circumstance, especially, and we have two ways of determining, we have kind of a couple different ways of determining if somebody has mono. You can do what's called a rapid mono test, which the only problem with a rapid mono test is typically if you do this blood test in the early course of a teenager having mono, it's often negative. In other words, the result you'll get shows, oh, there's no mono there, when that's misleading because the person still has mono. In my experience, you can correlate a monospot, which is quick, with a CBC, a blood count, so that you can understand, is the person's white blood cell count low, and do they have on that test something called atypical lymphocytes, because that's actually a little quicker way to understand, oh yes, this person has mono. The longer, most definitive way of understanding if someone has mono is to do the antibody testing, of which, especially nowadays with COVID, we've heard a lot about antibody testing. Mono is actually is the poster child for doing antibody testing and understand, does somebody have mono? Because what happens in a child, especially teenagers with mono, is that these kids stay sick for a long time.
Right.
They don't just kind of clear up. They're just lingering with ongoing symptoms, fatigue, not feeling right, just chronic sore throat for, weeks on end, not seeming to get better no matter what we're trying to do for them. And, mono, it's important to understand a child has mono because of the potential threat of their spleen getting enlarged and the implication that would have to their, physical activity, especially if they're in any kind of contact sports.
Right. You alluded in this discussion about mono with glands in the neck. What are those glands in the neck? What's their functions? What do they usually do? Because we have seen them getting enlarged with strep, as you said, mono, and a couple of other viral illnesses. We sometimes find them in the back of the neck or sometimes at the back of our head. And I was just wondering, what are lymph nodes and what do they serve purpose?
Right. So, the one thing in medicine is always that, the words we use to describe things do have a lot of importance. And the majority of the swellings that we get in the neck, and especially in the pediatric age, are the lymph nodes of our neck that are getting swollen.
Right.
Remember, when we use the word glands, that's a little bit of a misnomer when we're referring to lymph nodes, because we have salivary glands in our neck, of which there's two major sets: the parotid glands, which are in front of the ears, which is the classic swelling when we always hear of mumps. And then there are the secondary, what are called submandibular glands, which are underneath our jaw. They drain our saliva underneath the tongue. So when those are swollen, that implies different things than when the lymph nodes of our neck are swollen. In the lymph nodes of our neck, we have approximately 200 lymph nodes in our neck.
Well, so many.
Yeah, a lot. 100 on each side. Their function is similar to tonsil and adenoid tissue, right? They're all part of what's called the lymphatic system. Right. Their job is to filter out infection in the neck that's either coming from the throat, the teeth, or the sinuses to prevent those bacteria, germs, viruses from getting into our bloodstream. And oftentimes, as a result, in an acute illness, whether it's a pharyngitis or a tonsillitis, lymph nodes will get swollen in the neck. It's not infrequently that when one side gets swollen and you have a lymph node lingering for a little bit of time, that usually starts to cause a little bit of distress. We're concerned that, hey, is this just what we call a reactive lymph node in response to infection, or is this something more dangerous?
Right. Right. So the advice to the parents would be, if it's more than few days, if the lymph glands are getting enlarged, then basically seek medical advice.
Yeah.
Okay.
And understand, at some level, luckily bad things aren't that uncommon. Acute illnesses will cause, the lymph nodes to be swollen, oftentimes for several weeks. Right. It's oftentimes the characteristic of the lymph node, assuming it's not continuing to grow, get more painful, that will make us more concerned that we need, additional testing for lymph nodes to understand, hey, are these lymph nodes something that is okay in response to infection, or is it more serious? Pain, redness, and swelling over the neck and areas of lymph nodes is something that demands immediate attention and understanding. Impaired mobility of the neck. If your child is splinting the way that they move, in other words, they have to rotate their entire torso as opposed to being able to turn their neck, that's a sign that, hey, there's something probably more significant to the inflammation of a lymph node. This needs to be examined.
Great advice. So we talked in the earlier part of our discussion about tonsillectomy, and when I'm subjecting my 2, 3, 4-year-old child for tonsillectomy and adenoidectomy, what advice can you give to the parents whose child will probably put under general anesthesia? And what are the common things that you have seen happen, and how can you reassure our parents that generally surgeries are safer?
Yeah, if we get to the point that, the person has met the reasons for why they need their tonsils and adenoids out, surgery is going to be happening. Yeah. The surgery of tonsils and adenoids, something that takes place under general anesthesia. The child has to be sleeping so that they don't feel any discomfort while the procedure is being performed. And in the circumstance of an otherwise healthy child that doesn't have any, major structural, skeletal structural issues or other, significant diseases, fortunately, this is something that can be done in a safe manner. Typically, with anesthesiologists and the advanced anesthesia functions are normally very safe. I can't actually remember any major issues surrounding anesthesia for, routine tonsil adenoid, unless there's structural issues, in which case, then those cases are performed in a hospital setting, requiring the child to be, monitored overnight. But the majority of all tonsillectomy and adenoidectomy that we do, these are all done on an outpatient basis, and it's fine, right? What we have to be worried about, so I think most parents are always understandably, being a parent, everybody's worried about the anesthetic itself. Right. My experience, fortunately, that's not the main worry, right? It's typically the recovery of these procedures that's going to be the more stressful element in the long run, because taking tonsil and adenoids out, it hurts afterwards for the kids, right? You're going to have a bad sore throat, and we need to keep those kids hydrated to minimize the downward spiral of fevers after surgery, which tend to be more related to dehydration. And the negative effects of dehydration, the number one most worrisome side effect of dehydration being the worst, typically the worst complication of tonsil surgery, which would be bleeding. We don't want the kids to bleed. We always stress to the parents, manage the pain, keep the kids hydrated so that we can avoid that as a problem. So
tonsillectomy surgery is a very legitimate indication for eating ice creams and smoothies, correct?
Say that again.
Eating ice creams.
Right, exactly. Yes. We're talking about sweets are good. Usually what happens though is that by the end of it, the kids are, I always warn parents, by the end of week 2, watch the chips because there's been a lot of sugar going in, not much salt, and the kids definitely want to grab the chips at some point as they're feeling better.
Right. Well, thank you for a wonderful discussion on tonsils and adenoids. Any concluding remarks for our parents as a ear, nose, throat specialist practicing for 25 years? What do the parents take home message for tonsils and adenoids? Not all large tonsils need to be removed. If they are symptomatic, then we probably need to approach you. And obviously, be vigilant for other symptoms of swelling of neck, difficulty swallowing, and so on and so forth. So I just wonder whether you have any comments for parents.
Yeah, I would say that, the presence of, slightly enlarged tonsils is, in the absence of symptoms is does not necessarily, lead to the fact that we need to take them out, right? We have to look to what degree are the kids having infection, understanding that if those numbers are piling up on a single year basis around the 6-year mark, that we become concerned about too much antibiotic, potential detrimental effects of strep. And that's when we want to consider tonsillectomy. And the other major indication is, if the tonsils are so large that the sleep patterns are being disrupted, we understand that there's some potential negative consequences for attention span and stuff when the kids aren't getting their proper sleep. And in the cases that for obstruction, nowadays we can treat many times, especially like with allergy nasal steroid medicines, and alleviate these obstructions. But if they don't alleviate, then that's the kind of circumstance where parents should be thinking, maybe I should get a consultation and consider tonsillectomy.
Thank you, Dr. Marra, for a wonderful discussion. I'm sure parents would love it. These are the common things that we see in our pediatric offices, and if parents have questions, concerns about you, I appreciate your time. Thank you very much.
Yeah, thank you for having me.
You're welcome.